So for this task, we're going to go over monitoring anesthesia using anesthetic charts. So the first thing that I want to do while I am monitoring my patient is go ahead and determine the physiological status of my patient under anesthesia. So the best way to monitor your patient under anesthesia is with your own hands, basically through direct personal contact. So with your eyes, your hands, your ears, basically everything you can, just so you have your hands on your patients the best way. Sometimes, however, it's not always possible depending on the type of procedure that's being done. But we do have monitors that can help us as well in cases that we can't always have our hands on our patients depending on the type of procedure. So the first thing that we're going to talk about is heart rate. So heart rate kind of is important, and it tells us basically circulation through the blood getting to the organs and the tissues. And the way we monitor heart rate is either by direct contact, so palpation basically in the thoracic wall and feeling for the beats per minute. Another way to monitor heart rate would be through stethoscope. And if your patient's under anesthesia, you can either use a stethoscope and listen on from the outside, or you could use an esophageal stethoscope, basically down the esophagus. So it just makes it a little bit easier, and it's right next to the heart, so you have a nice good sound, so you don't have to mess around, especially, again, depending on the type of procedure that's being done, if in case you don't want to get in the way of the type of procedure. So normal heart rate for a dog is 60 to 160 beats per minute. And for cats, we're looking around 120 to 180 beats per minute. So at some point, if the cat or the dog heart rate starts to increase, so tachycardia, that might indicate that we need to turn our anesthetic up. And in other cases, our patient could be displaying bradycardia, which is too slow of a heart rate, which indicates they might be too deep and need the anesthetic turned down. So that just kind of depends too on patient status and history as well. We usually will go back in the medical record and just check previous surgeries if they've had any, to see if they've had any issues with tachycardia or bradycardia or any other issues previously as well, or ask the owner if they know anything. So the next thing we're going to check is the heart rhythm. So heart rhythm is usually monitored through the ECG, and so when we have our ECG leads hooked up to our patient, we monitor it here on this, on our universal monitor. It has different functions, but what we want to look for are smooth, regular patterns and smooth, regular beats in the heart. We don't want to see anything sporadic. Sporadic could tell us if there's an arrhythmia or some kind of block. We just want to make sure the pattern stays nice and even and steady. Sometimes certain drugs and medications could increase the heart rate and increase the heart rhythm and make everything kind of uneven too. So that's again where we make sure we look at our patient's chart and ask beforehand if the patient is on any medications, or the type of anesthetic drug we've used as well can cause them to have some abnormalities show up on the monitoring system. But again, that's why we do listen, just to confirm that everything does sound and look okay. So the next part we're going to talk about or look at for a patient's physiological status would be mucous membrane color. So mucous membrane color can kind of tell us a little bit about tissue perfusion. It's not the best way to monitor tissue perfusion, but it's one we've got, so we do monitor it fairly often. So basically, we look at the gum color, and sometimes if the gums are pigmented, we can look at the eyes and the ears, kind of give us an idea. Prepuce or vulva as well can give us an idea of color. But usually we look at the gum color, and what we're looking for is we want a nice pink color, nice like kind of salmon pink color. And we do monitor that on our anesthesia log as well. What we don't want to see is we don't want to see pale. Pale can indicate some kind of anemia. It can also indicate shock. So if we notice that, we want to tell our doctor immediately. Another one we don't want to see bright red gums. bright red gums usually can mean that they could be septic or overheating. Again, most of the time we do monitor mucous membrane color before we put them under anesthesia, but some things can change, such as if they were to go into shock or start losing a lot of blood, then we would know. Another one we want to look for while they're under anesthesia is if they're turning blue at all. So blue would be cyanotic, which would indicate that they're losing oxygen, or they're not getting enough oxygen to their system. So those are really important to look for. Another one is if the gum color or tissue color at all is yellow. Usually, again, we'll notice that before we put them under anesthesia, but that might indicate some kind of liver problem. So the next parameter we're going to talk about is capillary refill time. It's just another one we measure when we're looking at their gums. So basically, we'll pull lip up and we'll press down on the gum basically until it blanches white and then let go. And then we want to count the seconds that it turns back to the normal pink color. So what we're looking for in that is we want a nice, again, pink color. We want it to be about less than 2 seconds. If it's any more than 2 seconds, then we could have an issue with a poor tissue perfusion. And so again, we want to make sure we tell the doctor. But usually we'll have our SpO2 monitor on our patient as well. And usually on the tongue, doesn't always have to be on the tongue. But it would start to, we should notice a drop in our SpO2 before, we end up noticing the delay in the capillary refill time. So again, good for monitors to help us with their, actually I'm just going to keep that on, there you go. You don't always have to put the SpO2 monitor on the tongue as well. You can use another part of the body such as the ear or the prepuce or the vulva work as well. We just want it to be on a nice fleshy pink part of the body, sometimes in between the toe pads work as well. That's okay, yeah. So now we'll go on to talking about pulse and blood pressure. So pulse strength is a good indicator of blood pressure. So we do want to, see if I can make my doggy stand up here, measure the pulse strength, and usually we'll do that in the femoral arteries. You can also do that the lingual and then the carotid chest and the ear, but usually femoral. So we want to feel for a pulse. And then also we listen to the heart rate as well. We want to make sure that they match up evenly, and that should be done before surgery. You can also do it during surgery. But if you feel a good strong pulse that's easy to palpate, that's what we're looking for. What we don't want is it to be bounding excessively. That could indicate that there's an increase in blood pressure, or if you're having difficulty palpating, that could indicate there's a decrease in blood pressure. And then we also do monitor our blood pressure with our blood pressure cuff here. Oh, I think that cuff's a little small for your leg. So that way during surgery we can kind of keep an eye on the blood pressure. So blood pressure, basically we want the systolic to be about 90 to 160, the diastolic to be 50 to 90, and then the mean to be about 70 to 90. For some reason, if there is a decrease in blood pressure, we might need to, we'll alert the doctor, but we might need to turn the anesthetic basically down and increase IV fluids, and just kind of monitor all the other parameters as well, making sure the heart rate is okay, that it's not dropping, and making sure SpO2 is okay and that tissue perfusion looks all right. If those are all okay and the blood pressure is dropping, again, you might just increase the fluid rate on them. So that's just another one that we do monitor. So after that, we'll be monitoring respiratory rates. So usually when they take a one breath in and out, we count that as one, or basically an inhale and an exhale, we count that as one breath. And the way that we monitor respiratory rate, we either count it manually by watching the chest wall move up and down. You can also watch the reservoir bag kind of moving, and then there's also respiratory monitors and capnographs. Usually those monitor respiratory rate as well. And you can also kind of listen with your stethoscope as well if you can reach in there during the procedure. So basically, one way to get the respiratory rate is by counting the beat or counting the respirations, and usually about 15 seconds, and multiplying that by 4, and that usually gives you your respiratory rate. So normal respiratory rate for dogs and cats is about 8 to 20 respirations per minute. For some reason, if they start to get higher than that, then again, we usually is a good indication that either they're feeling it or they're too light. So we would turn them down. That would give us a good idea as far as anesthetic depth. And then if it's getting too slow, then we have a cause of concern as well. So you might have to, they may be too deep. You might have to turn them down from anesthesia. The other one that we like to check is respiratory rhythm. So again, kind of on our monitoring system with our capnograph as well can help us monitor the respiratory rhythm in the waves. As they exhale, it kind of plateaus, and then we kind of just watch for nice steady rhythm. We want, and we're watching our patient if we can, we want nice steady deep breaths. We don't want any kind of sporadic breathing. We don't want any panting that might indicate that there's going to be some issues. A lot of the times too, you need to check your endotracheal tube, because the tie could be too tight and that can be causing some problems. I've seen that before. So we want to monitor our pattern through here, and then our report on our paper. Another thing about monitoring respiratory rhythm too is you want to make sure you manually vent or manually breathe for your patient, turning off pop-off valve, squeezing the bag to about 15 to 20 centimeters of water, and then opening our pop-off valve too. That can help our patient significantly during anesthesia, just to kind of help it open up the lungs as they start to decrease. So another parameter that we measure during anesthesia is temperature. So temperature can tell us quite a bit. If the temperature is too low, then they become hypothermic and they might not be able to absorb the anesthetic drug all that great. Sorry, there we go. So we do monitor temperature basically throughout the entire procedure by just leaving the monitor with the probe on and through our patient. So normal temperature for patient under anesthesia is usually about 97 to 100 degrees Fahrenheit. And we do always use warming devices while our patient is under anesthesia, by either using like a warm water circulating blanket or a bear hugger or some kind of warm towel on top of our patient. And of course, at any point if our patient starts to get too warm, then we turn down the blanket or remove the blanket from on top of them. It's really important to monitor body temperature during anesthesia as well, and after anesthesia. And we always get a temperature before they go under anesthesia, just so we have a good idea that they're not running a fever, and also what a good idea their normal temperature is. And then so of course, while our patient, before they go under anesthesia, we do check just previously, checking blood work, checking history, making sure all my consent forms have been signed, making sure the previous, the exam that they've had before surgery looks okay. That way we can make sure that if something were to happen, that it wasn't something that we missed prior to anesthesia. And then also, while we are monitoring our patient during anesthesia, we do that for every about 5 minutes. And then we do have our anesthetic form here. So we record everything on here about every 5 minutes. We do record all the medications that were used, the dose, the route that it was given, the time that it was given. We also record recovery time on here. So we do monitor heart rate, mucous membrane, CRT, blood pressure, respiratory rate, and tidal carbon dioxide from our capnograph as well. SpO2, monitor our fluid volume that our patient is getting. We monitor temperature and thermal support as well. And then we always monitor the percentage of ISO given during surgery and the oxygen flow rate as well. it's really important to make sure that we record everything. And that is it for determining our physiological status, and then we'll go and talk about reflexes. So along with monitoring our patient's physiological status under anesthesia, we also need to monitor their surgical plane and surgical stage of anesthesia. And there's some different ways you can do that, along with measuring the physiological status, determining, respiratory rate and heart rate. Those things can also kind of tell you what surgical plane and stage that your patient is in, but there are some reflexes that we can check as well, just to make sure that our patient is going under anesthesia and they're at a nice depth or stage. So first I'll talk a little bit about the different kinds of stages and planes of anesthesia. So there's 4 stages of anesthesia, and under stage 3 there's 4 different planes. So the first stage of anesthesia is usually just before induction. They're sedated, they're kind of, wobbly, but everything should be stable. Heart rate might be increasing a little bit, respiratory rate might be increasing a little bit. Actually, heart rate will start to go down as well. Stage 2 is the excitatory stage. This is usually during induction, so we like to kind of get them through that stage really quickly. Usually they're struggling, they might be pedaling a little bit or paddling a little bit. Respiratory rate usually is increased, and heart rate is usually increased at that time as well. And then we have our surgical stage 3, plane 1. Usually they're unconscious, but they're light. And everything, respiratory rate might be, or heart rate might be a little bit increased. Respiratory rate at this point should start to become normal. It's usually when we start to hook them up to the anesthetic. And then we've got surgical stage 3, plane 2, which is usually what we call surgical anesthesia. And that's usually the ideal time to perform surgery. Heart rate should be normal, respiratory rate should be normal, everything should be kind of equaling out and should be good. That's the time for you to do surgery. And then you've got stage 3, plane 3, which usually like a deeper anesthetic plane. Usually the heart rate will decrease a little bit, the breath will become a little more shallow. So at that point, you should probably monitor your patient and either turn them up or figure out, what to do at that point, tell the doctor. And then you've got stage 3, plane 4, which we consider to be pretty deep, very deep. At this point, respiratory rate might start to become a little more shallow, and your heart rate will start to decrease. At this point, it needs correction. So immediately, you need to turn your patient down from anesthesia, tell your doctor, figure out what corrections you need. You might need emergency drug at that point as well. And then you've got your last stage, stage 4 of anesthesia. Usually that's apnea stage. You're looking at cardiovascular collapse at that point as well. And so you really want to monitor your depths of anesthesia and your stages, just to make sure your patient is always good and not too deep. So move on to our reflexes. So some of the reflexes that we're going to look at to determine their plane of anesthesia while they're under, first one is the ear flick. So basically touching the ear just a little bit. Usually they'll kind of flick it themselves, and usually at that point they can either be light to moderate. So that's a good one to measure to see where they're at. And then our next one that we have is our pedal, or our withdrawal reflex. So this one you usually pinch, and you pinch with a fair amount of pressure between their toes, and you kind of can pull on their leg a little bit, and what you're looking for is some kind of reaction, usually withdrawing their leg and pulling that away from you. When that is absent, or when that reflex is gone, usually at that point it's okay to start to intubate your patient. So the next one we'll talk about is the palpebral, or the wink reflex. So usually what you'll do is on your patient here, let me see if I can get my eye. Usually you'll take your finger and just kind of tap here on the medial canthus of the eye, and what you're looking for is some kind of winking reaction from them. Usually when you're at your stage 3 of plane 2, your surgical anesthesia, that should not be present anymore. But it's good, you can use that one as well while they're recovering from anesthesia, just to see, when they're coming back at what point they are at. The next one we'll talk about is not really common. It's the corneal reflex. So usually you apply some kind of light pressure on the cornea. It's usually take like a drop of saline and look for basically same kind of reaction, looking for some kind of wink from them or reaction from them as well. So like I said, it's not very common. Another reflex we check for is jaw tone. So basically what you're looking for is them to be kind of have muscle relaxation, and so jaw tone should be nice and loose and fluid. At that point, you don't want to intubate when they have much of a jaw tone. You can injure yourself, but that's a good one to measure as well, just by kind of gently pulling and seeing if you feel any kind of resistance. So then another one we'll check for is laryngeal, or like the swallow reflex. Usually you can initiate that by kind of gently rubbing the patient's throat and seeing if they have like any kind of swallow reflex. At that point, usually when it is gone, it is okay to go ahead and start to intubate. But we also like to monitor that when they're recovering as well. So usually we won't extubate them until they give us about 2 or 3 good hard swallows. We just want to make sure that that reflex is present, just so they end up having, they don't end up aspirating, they don't pull the tube out too soon, and they can't control the laryngeal part of their body. So then next one I'll talk about here is eye position. Now eye position can tell you a lot under anesthetic depth. So it's important to make sure you monitor that frequently while your patient is under anesthesia, especially if anything starts to change as far as your physiological status goes, heart rate, respiratory rate, if your patient is breathing a little bit heavier, respiratory pattern, so you want to watch that. And so with our eyes, the position basically, so you can have, when they are light to moderate, they can be in a ventral position. So we want to make sure, usually that is where we like them to be, the eye position, usually surgical plane anesthesia, they'll be in like the ventral position. And then if they are perhaps too light or too deep, then we can see their eyes will be in central position. And usually if they're in central position and they're pretty deep, we don't like that, so at that point too you can intervene. So it's, like I said, it's important to monitor that, those eye patterns. And then respiratory pattern is another one we like to just monitor. Again, just kind of, you can monitor the respiratory pattern with your capnograph, and just monitor for any kind of changes, trends. You want to see a nice smooth pattern. You want to see nice deep breaths, regular breaths. You don't want anything that's really too sporadic. You don't want them panting. Sometimes that can indicate that they're not in the correct plane of anesthesia that you need to have them in before you start surgery, so they might be too light. And then of course if you get jerky motions as well, that could mean that they're in stage 3 plane 4 at that point, which is too deep. You just want them to be nice and regular, and just monitor that very frequently. So it's important that you monitor both the physiological and the anesthetic depth and plane, just because they kind of go hand in hand with each other. All those parameters should be monitored and recorded on your patient's anesthetic monitoring form. And of course, if anything is within, out of the normal limits, you should alert your doctor, so you can start to intervene and correct as you need to. And that is it.